Now, on to our program. David Ricks was born about 3 hours south of here in Bloomington, Indiana. Grew up in California, but found himself back in Indiana for college at Purdue, where he received his Bachelor of Science in 1990. After a stint as an account rep at IBM in New York, he received his Master's in Business at Indiana University, where his then girlfriend, now wife, Christina, was in medical school. We actually have alumni tables here tonight from both Indiana and Purdue. It was not his dream to work for a company for over 25 years in the town an hour from where he was born. But that's what happened. Dave started his career at Eli Lilly in business development in 1996, where he worked on mergers and acquisitions. Various positions in sales, marketing, and drug development in Canada and the US led to him being named president and general manager of Eli Lilly China in 2008. In 2012, he was appointed president of Lilly Biomedicines, then the company's largest business unit. He was named Lilly CEO in January 2017, and later that year was appointed chairman of the board. You may not know that Eli Lilly does not actually identify itself as a pharmaceutical company. Their site refers to Lilly as a medicine company that believes health is fundamental to our lives, a distinction that 58 million customers have experienced with medicines like GLP-1 injectables, Mounjaro and Zepbound, or the just-cleared Alzheimer's medication, Kisunla, which represents a major breakthrough as one of the most effective treatments to date for slowing the cognitive decline associated with Alzheimer's disease. And we have all read about their latest GLP-1 pill with the potential to dramatically increase access and further democratize health care. All of those medicines were developed during Dave's tenure as CEO. Over the last 8 years, his R&D spend doubled, their stock increased more than tenfold, and revenue doubled to $45 billion. Lilly's market cap is now over $700 billion. They recently announced the formation of Lilly Direct, transforming the pharmaceutical giant into a pharmacy for the first time, and slashed prices on insulin to $35 a month. Others have followed their lead. But he is still a boy from Indiana, where Dave is heavily engaged in the development and well-being of Central Indiana and serves on the executive committee and board of Central Indiana Corporate Partnership. And Lilly has invested $9 billion in new manufacturing facility and recently announced an additional $4.5 billion for the Lilly Medicine Foundry to be built in 2027, all in Lebanon, Indiana. So I ask you now to welcome to the Economic Club of Chicago, Eli Lilly CEO, Dave Ricks. Dave, I just want to jump right into the deep end if we can.
Let's do it.
And we've had a lot of fun, but I want to get right in and deal with a persistent rumor I think that we've all heard. Is it true that your wife deserves 100% of the credit for you being at Eli Lilly?
It is true. And I've got a number of my colleagues here at this table who now not like her as much, I think, after this. No, I say it's true. I joined the company for love. Not love of the company, love of a girl who was going to medical school in Indianapolis. And if you've been to Indianapolis, it's a beautiful town, not quite as big as Chicago. There's not that many places to work if you've got an MBA. So Lilly was the one, and that was 29 years ago.
Right. Okay. Yeah. So is it fair to say that you did not grow up dreaming of becoming the CEO of a global pharmaceutical giant? And if so, you were born in Indiana, you moved to California, grew up there, came back to Indiana for education, went to New York, came back to Indiana for education. What did you dream about during that time period becoming, in your professional career?
Yeah, well, I was born in Bloomington. I only lived there as an infant. And I often joke, I spent most of my life trying to get away from Indiana since then, but very unsuccessfully. But it's home now, and we love it. I mean, I don't know, like every boy, I grew up, I wanted to be a professional baseball pitcher.
Yeah.
I was okay at that, but not good enough. I went to Purdue and then in the tech business. I thought that was interesting at the time. Got really close to it and decided maybe something different was okay. So to be honest, I didn't have a master plan. And it wasn't until maybe, 14, 15 years ago that I even thought about being the CEO of Lilly or any other thing, to be honest. And I think maybe that's a good way to go through life. I think if you have too many of those, it's good to have long-term goals, but they have a way of disappointing you if you're too specific. I really liked about Lilly that we're a staff from within company primarily. We grow most of our talent. We focus on, kind of the most probable person to be great versus the most qualified person today. And time again, the company put me in jobs I had no business being in. I really was not qualified for, but was able to learn and then go to the next one. And I'm super grateful for that because I think today, if you're just jumping companies, you tend to get narrower and narrower, right? You get better and better at one thing instead of better at many things. And I think for the work I do every day, it's definitely a multi-topic world. Yeah. You're skipping between many different things. And I would not be prepared to do that if I hadn't grown up in the company I did. So super grateful for that. But yeah, most of the time it was just do well today and there'll be another job. And I was learning and enjoying it, and it was great.
Yeah. We hear a lot about this concept of Lilly Nice as part of, and can you put that in context for us? Is that how the culture is described? Is it something that described the culture of the past? Is it still relevant today? If we walked into your headquarters, is there a big sign in neon that says Lilly Nice?
Lilly Nice.
Help us understand.
Yeah, that's a saying people would say. If you join the company, probably you get that feeling too. Like, is this real? Are these people real? Like, they're very friendly. I'm sure Chicago's a friendly town.
Absolutely.
But in Indiana, it's like a wholesome friendliness, and it is real. I think part of my job is to keep the good and tune up the rest. Mm-hmm. That's the culture ambition we have. And there's a number of good, and I should step back, it's almost a 150-year-old company. It'll be 150 in May. And there's only a handful of US companies that can say that. Yeah. For the first 100 years, it was run by the same family. And they had really clear values, and one of the key ones was what we call respect for people, and it was a very respectful place. At our best, that's a place where everyone has a voice and different groups can come together. It's a very multifunctional business. I'm on the board of a software company. There's really only two kinds of people in software companies. There's engineers and everyone else. And the trick is getting those two groups to get along. Yeah. Yeah. At Lilly, we have all kinds of different people. The chemists make fun of biologists, and the business people don't listen to either of them. And we have this huge variety, and that's challenging. But the nice part helps it kind of congeal and come together, and people can get behind a shared thing. But at our worst, it's sort of the nice that where you don't tell the truth. Yeah. And you don't solve real problems. And so I always thought in this job especially, it's my job to sort of wash that stuff away, bring out a little more competitive spirit, not with each other, but with disease, with the outside world. And make sure we're being frank when we have to be.
Yeah.
And I think that's a better version of Lilly. So you can keep most of the nice, and when you need it, go to the other pieces.
Yeah. Speaking of change, when you became CEO in 2017, is that right?
January 17.
Was there something about the company at that time that you decided, hey, obviously you have more than 125 years of great success, global pharmaceutical company, terrific track record, but was there something about Lilly that you decided, I have to change this in order for the company to go to the next level, for the company to enjoy the type of success that you are enjoying today? Were there one or two things that you decided we have to do this differently?
Yeah, there were. And I had known the company for a while. There's a plant manager I got to know when I was in China, this guy named James Tu, who he sadly passed away actually of cancer. But shortly before that, he told me something, and in this sort of that Asian way, it all sounds like you're kind of getting a piece of ancient wisdom. But he said, to be a great plant manager, you have to love a plant enough to break it and put it back together. And that kind of stuck with me. And I think when I became the CEO, I really loved the company. I still very much do. But I think you have to be not afraid to push it to be a lot better. So I think if there's one overarching kind of arc, it's like the ambition for what we can do. I always felt like whenever I heard something that was short of change the world, at least the health world, it disappointed me, and I wanted to push for that. Probably a few themes within that. One was this piece about working together, but not just to be nice, but to win. And I think that's kind of been a theme, and we built a framework around that and an expectation. Another one is external focus. So down the road there in Indianapolis, and at Lilly, so it's kind of a one-company town. I don't know if you guys know that here in Chicago, but we're a big entity in a small place. And everybody who you go home to on the weekends either already works at the company or wishes they did. Yeah. And they're very nice to you, and they thought, oh, that's great, your life must be fantastic, and everything's good. You work at Lilly. But that's a real problem, because a lot of people, other companies are trying to beat us, and a lot of interests are not on our side, and we need to have an outside-in view. And I think that's changed quite a bit in the last 10 years as well, which is fantastic. What hasn't changed is the bet on our people, the bet on being a core scientific institution, and we've doubled and tripled that again. We'll spend $14 billion on R&D this year, which is really like at the nation state level. Yeah. Total NIH will be $40 billion. So we're like a third of the NIH. That's kind of amazing. We have more than 4,000 PhDs doing research. That's more than MIT or Harvard. So we do real science, and we do it at scale, and I think that's very important to who we are and always has been. But adding that outside-in view and kind of collective performance, I think has been key.
Was there any sort of key to success for you in actually bringing about meaningful change? And some of that even sounds like it's cultural. There are a lot of CEOs who identify in both large and small companies exactly what needs to be done in order to affect something remarkable within their company, but it's the execution of it that falls short. Is there something that you could point to, or is there some key that...
Well, like everything, it starts with who you put in what job. I think that's sort of the ultimate leadership superpower you have. And if you settle, then good luck to you. I think you really need to be super thoughtful about that, especially at a senior level. Those appointments are not just a person and a leader, it's a message. And I think you got to send those messages explicitly, very clearly, and know what you want to do there and get that across. And of course, expect that person then to follow through on that. That's key. And so, that's a key thing we did. We moved a lot of things into this external focus, customer and also external R&D, very successfully. And I think when you're in the CEO job, a lot of my peers I talk to, they kind of get tired of talking about the change agenda. And it's like, how many times do I have to? And the answer is until it's done. I think you just have to be so relentless. In a big company, and we have, almost 50,000 people now, more like 40 when I started, that takes that's a lot of inertia to get that thing to turn. And you're just one voice and one person. You might be the most powerful, but you're not omnipotent. And so I think being completely relentless and pretty focused, so you're only talking about 2 or 3 things all the time until they're true. Yeah. The amazing thing to me, my lesson through this job is actually the words matter, but not that much. What matters is like what you do and pay attention to. And people really unconsciously or consciously follow that. So again, I've watched leaders of mine in the past and leaders in other entities where they complain that, hey, I'm not able to create the change, but then you watch how they spend their time and it's like, yeah, because you're not changing.
Yeah.
And so I think that's been a key as well.
Yeah. So GLP-1s have just taken the world by storm, right?
Incredible.
And so I think to the general public, it probably seems like it's an overnight sensation, right? That just suddenly someone went into one of your labs and the next day it popped out and we're off and running.
Here we go, yeah.
Can you back us up and talk to us about the actual story behind it in terms of the discovery, the development, the time that was involved?
Yeah, I mean, drug development, drug discovery, and we do discovery. I think that's a little bit different than most every other industry. I mean, literally we create new matter that didn't exist in the known universe to do a job. That's a difficult thing to do, by the way. And we then have to prove that new thing does what it's supposed to do and not anything harmful. And then, then you hear about it. That process can take, at best, 10 years or maybe a little less than that sometimes now, but sometimes longer. So we marketed the first GLP-1 medicine in 2006 in the United States. And you probably never heard of it. Yeah. And I think we were trained a little bit during COVID that there was this idea that there's like a laboratory and we've just put enough smart people in it. There'll be some big light bulb will go on. They'll make a medicine and then a few months later we'll have it. And that happened in COVID, which is incredible, but that is definitely an outlier. More of the story is often there's a good idea and it works okay, and then you have to improve it and improve it again and improve it again. Sometimes those become marketed products. Usually they don't, and you don't get any revenue. Yeah. You mentioned some good remarks at the beginning, and we have many members of the Alzheimer's Association, and the U.S. Association is based here in Chicago, actually. And we worked for 34 years, and I think had 6 late-stage failures before we had a successful medicine in Alzheimer's. None of them made it to market till the last one. With GLP-1s, the first one did. It was a twice-a-day injection for diabetes. If you look at the cover of our annual report that year, there's a picture of a woman with a quote that's saying, hey, this controls my blood sugar and I'm losing a little bit of weight. So there you had it. There you had the insight. But it was a twice-a-day medicine. You couldn't dose it enough to really lose a meaningful amount of weight. Certainly not enough to get an FDA approval for that. So the scientists went to work in solving one of those problems, which was really the twice-a-day problem. We created a once-a-week version, which was known as Trulicity or dulaglutide, which was widely used, our biggest-selling medicine ever just 4 years ago. And that began to give us some insight into, okay, these could really powerfully change diabetes and maybe consider other chronic diseases. Our competitor, Novo Nordisk, copied that in a way and created a more potent version that they could dose even higher. And credit to them. They did the first big study in obesity and in cardiovascular effects of obesity. And we followed that with Mounjaro and Zepbound. So we're sort of like leapfrogging and hear the success of innovation story begins to take off. But for us, these processes take 7 or 8 years. And people often say, well, when did you know that Mounjaro, Zepbound would propel the company to this? And I know when I knew, which was in April of 2018. That's a long time ago.
Yeah.
But really, since then, it was just pure execution. I had almost, I would say 90% probability this was going to be one of the biggest drugs ever in the world. By the way, in Q2, we haven't reported Q3 results. That'll happen on Thursday. But Q2, it became the best-selling drug in the world in just 2 years.
That's incredible.
Why? Because it changes a fundamental biological process in a positive way. Like a lot of things in chronic disease, which is our major problem in cost and in human suffering in developed world, these are actually like genetic traits that were good when we were evolving as, on a plains of somewhere in a cave, but are no longer good. And now we live in a world of excessive calories and so forth, and we can't easily shut that off. That was a good trait before. You didn't starve. Now it's a bad trait. You get metabolic disease. So this solves that problem, and it's about 40% of human suffering on a planet level. It's a little more than 40% of U.S. healthcare costs. We can see a world now where we can make that go away, actually.
How does it actually work?
Yeah.
What does it do?
So we all just had a nice dinner. Everyone eat? Yep. And so your body right now is producing GLP-1 and about 7 or 8 other signaling hormones from your gut to the rest of your body saying, I ate, time to stop that food desire and start the process of using that energy or storing that energy. What it really does is boost, tirzepatide's 2 of those, Ozempic's 1 of those. It boosts 2 of those signals, and so it sort of amplifies a natural process in a way that's good enough to reduce appetite and actually, in some ways, speed up the metabolic process so you're less efficiently using that energy. Sure. And that's a good thing in modern society. As a result, cardiovascular risk drops, diabetes risk drops, and we're now learning about many, many other diseases that are linked to this, like inflammatory diseases, even some brain conditions, which we can talk about here, that are surprising findings, actually. But when you think about metabolism and energy is such a core part of our biologic need to exist, maybe not so surprising that so many things are linked to that.
Yeah, I believe, and you referenced that it's now the largest drug in the world, and I believe your year-over-year sales for the first half of the year or for the second quarter doubled?
For that medicine,
for
the total
medication.
company was up about 40%.
Okay. And so now with this particular drug, it maybe GLP-1s may represent north of 50% of your overall
A little
revenue?
more than 50% now, yeah.
Well, help us put into perspective the overall market for GLP-1s, both domestically and globally.
Yeah, well, we talk in terms of patients. I think today in the US, there might be around 10 million people taking these medications. When I say that, people are often surprised because we all feel like we know 10 million people who've been taking these medications. But that's not true. Probably, and here touching on one of the key problems we have to solve, which is access and affordability, and we're committed to solve that. Mm-hmm. But in the US, most estimates say there's more like 120 million people who are overweight or obese who would be good candidates for these. More than half of those have a chronic disease already from that condition. So we have a lot of work to do. We are literally like less than 10% of the way through this in the United States, let alone the rest of the world, where, with the developing economy, with the modern way of living, the American way of life that we've exported, we've also exported chronic disease. Yeah. And so places like India, China, Brazil, these are some of the fastest growing areas where chronic disease is becoming a dominant factor. Obesity, overweight, a huge issue. Diabetes, a huge issue. So we have a lot of work to do. We're just scratching the surface of all that.
And you're introducing an oral GLP-1
Yeah, and this is key to solving this problem. So today we sell these injectables, and if you know someone who took it, it's not really that obtrusive. It's the best form of an injectable anything. You can barely feel the needle. They're usually in an auto injector, which is, you don't even see the needle. Pretty painless, once a week thing. But on our side, scaling that at a reasonable cost is extremely difficult. It's a peptide, which is a biologic type product in very sterile conditions, has to be manufactured. Think, manufacturing workers in spacesuits, and in a complicated device. So there's a rate limiting step. It's really kind of linear. There's not a lot of learning curve associated with this. We're bringing a lot of that capacity online. We've basically, last year at this time, if we were doing this, you'd say, why can't we get enough? Why don't we make more? And we've solved that problem for the US and other development markets. But to really produce more, and it's the economic club, so we know that more supply should decrease pricing, then we need something that's simpler to make. And although the molecule that is the oral GLP-1, or forglipron is the chemical name, we'll think of a better name, don't worry, is complicated, and kind of a miracle that it works, actually, because we took this sort of protein that, think of something like this big in the body, and we're just using like literally the active part on the end and mimicking that with a chemical structure. But we can make that in chemical production, which is highly scalable, has big learning curve effects. It will be in a tablet or capsule, and we can build a lot of volume. And we've already made actually billions of doses preparing for the launch, and that will make this sort of the GLP-1 for all, and I think really make a difference in human health at a global level.
We're starting to hear more and more people talk about having been on the medication, losing weight, feeling great about it, coming off the medication, and the weight coming back on.
Yes.
How do you think about that, and how do you address that? Is the only answer that you stay on the medication, or is there a different path?
That's the current answer for most. I think some people can successfully come off, but it really would require you to change a lot about how you're living, which people, turns out, don't like to do. And so that's hard. And because our environment, which is the modern environment, is a calorie prolific environment, and our energy expenditure is one of low energy expenditure. Yeah. So that's, you have to change those two things, or you're going to gain weight. And I think we are learning that people who have had higher body weights actually are more resistant to keeping that weight off than those who have not. So that's a kind of defense mechanism our ancestors gave us, thank you very little, that allows us to sort of preserve calories in a calorie-restricted world, which we're not in anymore. So the answer we give now medically is to stay on the most effective, lowest dose you can stay on of the injectables. We're actually doing a pretty important study to rotate people randomly, either to stay on that or to keep going on an oral, switch to the oral medication, which I think is a little less intrusive, might be easier for people to manage, and probably we can get the cost down, which is a major reason people discontinue. Hopefully we can get the coverage up and the cost down. I think for those that work in the health insurance world, it really is odd when you think about it that we take like an antihypertensive medication. A lot of Americans are on those. The day after you stop taking them, they don't work either. Your blood pressure goes up, and yet we don't think about that and we cover them. Here, the major objection to the GLP-1s is when you go off them, people just regain the weight. It's like, well, yeah, that's what the medicine does. That's actually how it works. So we're working on that hard so that employers will cover, and we can have people be lower body weight and we'll all be healthier, especially as we age. I think that's a super important thing for chronic disease of the elderly. And if you care about Medicare and its solvency, this is probably one of the few strategies we have to continue that. So the oral's key for both breadth of coverage and continuing to help people keep their weight off and stay healthy for longer periods of time.
I think I heard, and maybe you mentioned this in a podcast, this could go in any number of directions.
But, which podcast?
You have maybe close to 100 studies going on right now
easily.
for different applications for
Yeah.
GLP. Can you talk about that? And are there some that are really surprising or more promising than others, or what?
Yeah, that's, I think, again, revisiting that comment about the surprising effects. Of course, we're pursuing every non-surprising effect. So that's, diabetes. We've done diabetes prevention and demonstrated that. We have big cardiovascular outcome studies because that's an obvious effect of lower body weight, and still the number one killer in the U.S. is strokes and heart attacks. Even though we're all on statins, seemingly, that hasn't solved it. I think these drugs can make a big difference in that. But there's many other interesting effects. We have an indication for sleep apnea. I was mentioning that because you've got Magic Johnson coming to the Economic Club of Chicago. Tomorrow we have Shaq coming to Lilly. And so Shaq's going to speak for us about obstructive sleep apnea. You're like, that's weird. Does it help with sleep? Well, sleep apnea is in part caused by obesity. But then you can get further afield from that. We have another medicine that will read out a study later this year for knee pain. And it is a powerful weight loss drug that is triple acting. If you think Mounjaro is double acting, this is triple. But about half the joint replacements in the US for knees are in people who are overweight or obese. And there's a mechanical kind of force loading that causes the knee to break down and wear out. There's also an acute reduction in inflammation when you use these drugs. And so we want to see if that can result in a use that would be, I think, quite helpful to many, many people and save money, likely. There are other conditions in inflammation that we have studies coming out later this year, reducing the manifestations of psoriasis, of ulcerative colitis and Crohn's. So these are, kind of chronic inflammatory diseases. Usually we're using that on top of standard of care, but to say, can we improve people's lives further? Those are likely to work based on the anecdotal evidence we have, and I think pretty exciting and new. Then you can go to the brain, and this is where it seems less intuitive even to our scientists. We're not totally sure the mechanism, but we observe in trials that people drink less, smoke less, gamble less, online shop less. So seriously. So there is this sort of dopamine kind of, this what we call the hedonic kind of desires, where you just keep hitting the button because it feels good. And it does seem to tamp that down.
Yeah.
And if we think about our society, kind of number one on the list of ailments must be things that are centered on this obesity and the metabolic conditions I spoke about. We all know someone who's had stroke, heart attack, or diabetes certainly, and kidney disease, all the things that flow from that. But another one we have to worry about, and here I would say particularly in younger people, are brain diseases and disorders. So it goes beyond those addictive diseases, which are major problems in our society, and we will study opioid use disorder because there's a good hypothesis here as well, and goes to even mental health. So it's interesting, the VA did a big retrospective look at their database and demonstrated that for people with serious mental health disorders who happen to be on these drugs for other purposes, had really significant reductions in their symptoms and hospitalization rates. Bipolar disorder, schizophrenia. This is not predicted, but it apparently is true. So we're going to work on those diseases, major depressive disorder as well. Yeah. And I think, while we may not know the exact reason, if it can be true, we should pursue it, because those are also major burdens of society. And if we can have a medicine that addresses those, that's our mission.
Yeah. I would imagine that every CEO in your industry goes to bed every night and prays for a blockbuster like this. Is there a flip side, though, as you see this blockbuster become a larger and larger percentage of your overall revenue? And there's this thing hanging out there. I mean, you're not Coca-Cola, so you don't get to invent something and live off of it for 100 years.
We don't put the secret in a safe.
We publish it. There's a patent. Yeah. There's a patent cliff, right?
Literally, we publish the recipe.
Yeah. So do you worry about?
We're good.
Do you worry about that, and how does that factor into your overall strategy?
It's a great question, and I think, I would say we worry, but in a good way. You know, some kinds of stress are bad and some are good. I think mostly it's good as long as you have enough time to get in front of it. There's two things about our industry that are incredibly poorly understood, and since I have 500 people listening to me, I'll explain them. One is that every single incredible invention we make becomes virtually free in the long term. We like to talk about expensive drugs and drug pricing as a major problem in our healthcare system. It's really not. What we're talking about is new drug pricing. But old drug pricing is the best deal going in, not just in healthcare, in anything. I mean, we invented Prozac. It costs 3 cents a day in the United States. I can't think of any other product I can buy that costs 3 cents a day. It's incredible, and it addresses major symptoms of depression. And Mounjaro and Zepbound will be like that too, let alone the oral pill. We just have to wait for it. And why do we have that period? To reward the incredible risk-taking and investment it takes to create a new medicine, which is about $3 to $4 billion and 10 to 30 years of time. If we don't have the reward period, we won't get an investment, we won't have any new medicines. So I think that's an important kind of message we have to share better. But at a company level, there are no successful drug companies made up of a bunch of little products. That it's a very asymmetric return that we need to cover all the failures. So we do all wake up thinking, I just need a blockbuster. Yeah. And if you don't have one, you really wish you did. And if you have one, you're thankful that you do. But you also better be nervous about the first thing, which is in 10 to 12 years, it's going to zero. And if you don't do something about that problem, you'll be out of a job, and so will everyone you work with. And so I worked at Lilly when we went through that. Yeah. It was not pleasant. I don't want to be in that period again, nor leave the people running the company after me in that situation. So we're investing like no one else in R&D right now, and we're looking for not to have a blockbuster. We just want more of them, and we want one after another after another. We've talked a lot about the GLP-1s, this class we call incretins. Tirzepatide is the one on the market. We're going to launch 2 more in the next 2 years. We may launch 1 a year for the next 5 or 6 years. So that's one way to beat this problem, which is create better and better innovations, like we think about upgrading our phone or whatever, that actually beat the old thing by enough to make it worth it. That is hard because we don't live in the world of engineering, we live in the world of discovery. So you actually have to discover molecules that do that. But I think we have good line of sight to that. But the other big strategy, of course, is to invest in other problems that can produce major solutions, which equal blockbusters. So we're doing that too, and that's equally important to us.
Yeah. How do you, when you're in the middle of writing a blockbuster like this, how do you balance the desire to push the R&D spend in that direction versus you know, you're in oncology, you're in immunology, you're all these other areas with really, you know, important, you know, discoveries and developments that need to occur. Yeah. How do you balance your commitment in that?
Yeah, you put your finger on, I think, one of the key failure modes actually that can happen. So we have to do 3 things in R&D at once. We have to, if you have a new medicine, it's a molecule we created. You want to maximize its utility. That's a normal thing to do. And since you already have it, you might as well do that. But I think here the history of the industry is probably overshooting on that. Probably after the 4th or 5th indication or use, typically the next one's less valuable than the first. And you get this diminishing return. But if you've got that blockbuster, it's like, why aren't you investing? That's always in your ear from investors and others to do that. But our belief is we should probably do most of that very early in the life cycle of the medicine, that our best ideas have come first, and that we're better off than doing the next thing, which is see if we can create a better one. But here it needs to be truly better, because eventually you're competing with free. That original medicine will go to 0 or close to it, 3 cents, and you have to have something that you can get a premium for to get a return on your investment that is actually substantially better. And so that's mistake number 2, is that we don't set the bar high enough on successive molecules in the same category. The third is to look where no one else is looking and try to create something useful for another health problem. And probably like a lot of industries, you get market analysts and people tell you where all the success is. And today, if I walked into a boardroom of any drug company, it'd be surprising if they weren't saying, how do you be more like Lilly, and why don't you have a GLP-1 that's selling billions and billions of dollars? The problem with that is the moment they start putting resources against that, they have to wait some period of time. By that time is up, pretty soon ours is going generic and they're just launching and it's no better and they don't do very well. So you have to look not where the market is today, but where the problems are today where there is no market. That's our belief. So what's Alzheimer's is an example of that. There was no therapy, now there is, and the market's developing too slowly, but we have a solution that's slowing Alzheimer's by 30%. We have that same drug has a study coming out in the next couple of years that will try to demonstrate slowing before the symptoms start. So that's pretty interesting. There's nothing there either. You mentioned cancer. I think here's another area where there's been huge incremental success over time, but really less than once a decade there's a real breakthrough. Yeah. So I think, can we find something that really makes a step change in killing tumors and helping people survive much, much longer? And then there's other conditions, you mentioned immunology, but actually we have sort of an idea now that we probably should be looking for new medicines and spending research dollars in places where there are problems but no medicines. Mm-hmm. That may be the next GLP-1 category, and we have to put some resources there. Like everything in business, it's, balance, choice is probably better than all in until you really have evidence that you have something there, and that's the mode we're in now. But those kind of threefold strategies are things we all use, but not one at the expense of the other.
Okay. You, Eli Lilly, you were investing in the United States to the tune of billions, even before the current administration started to push for it. Can you talk about that strategic approach? Is it a reflection of how you perceive the competitive and regulatory environment outside the United States? You served as a CEO and general manager in China back in the early 2000s. You obviously do a ton of business in the EU. Can you talk about your investment decisions and how that?
Yeah. Well, I think for us, there were sort of three things that came together there. And I should say, for about 40 years, we didn't build new manufacturing capacity in the United States. Actually, nobody did. Why? Because we had, this liberalized trade kind of globalization agenda, and countries that needed industry that didn't have them would offer to us special deals, basically tax reductions. And our cost of goods is not very labor dependent, so you can move materials around, but we are very tax sensitive. So these small island nations recruited a huge investment from the pharmaceutical industry, and the CapEx went to places where there was low tax rates. Of course, every year we would point that out to our policymakers in Washington and Germany and other places that were losing that industrial base, but no one paid that much attention. But that began to change actually in 2017, 18, the tax rate went down for a while. It was just made permanent. That's an important ingredient. 21 is not 35 on the corporate rate, and that difference that's a big difference for our investors and for other high IP industries. The second thing was the pandemic, which really, I think, taught us a lesson about redundancy or lack thereof. And for 40 years, we sought to optimize on efficiency, like every other industry. And then when you had, particularly for health products, borders closed for policy reasons, and you couldn't move medicine from country A to country B, including our country doing that to other countries. Yeah. It was an issue. So we took a policy decision at our board to create more redundancy and resilience at the cost of efficiency, but to make that trade-off, which was a cost that we'll have to bear. But the most expensive thing for us in a business that has 80% gross margin is the lost sale, not the cost of goods. Yeah. So that made sense for us. And the third thing was the success of Mounjaro and now the subsequent products and other products is driving huge volume. And then although we're trading with a high multiple and we're an IP-driven industry, we're not a software company. We don't ship digits, we ship goods.
Yeah.
And so we have to make them. So basically we decided to put most of our growth back in North America, back in the US. The tax rate being permanent was helpful. But it started in 2000, actually, in North Carolina. We announced our first plan in the Research Triangle to make Mounjaro, tirzepatide. That was 2 years before the phase 3 readout, 3 years before we launched. And yeah, I thought if that didn't go well, it would be a big problem for me personally, because that was the biggest plant we had built in a long time. We then built another one 2 years later down the road in outside of Charlotte, and we've just kept going, basically. Now we're doing one every 5 or 6 months to support the demand.
Yeah. The current administration does seem to be very focused on pharma.
Yes. I wish they were focused on airlines or someone else.
There's always tomorrow.
There's always tomorrow, yeah. There's always tomorrow.
Yeah. And so, and there's a sort of a common theme out there around pricing.
Yeah.
This notion that.
Sorry, sir, please use this.
Oh, thank you. Sorry, I'm a little too. What?
Dramatic.
I'm a little too dramatic. That's what my wife says. So there's this theme out there that U.S. folks in the U.S. are paying higher prices than people outside the U.S. for the same drugs, and this sense that they are in some way making it possible for the pricing to be lower outside the U.S. by paying more inside the U.S. Can you help us put all of that into perspective? Is that, and how should we think about that, and what is behind that?
Yeah, happy to talk about that. I think like a lot of things, we won't get political, but with this administration is that point is not wrong. The method to fix it, we can talk about. It is true. We all know this because as consumers, we can look at the price, even the net price in the U.S. So U.S. has a very peculiar healthcare system versus the rest of the world in that nobody pays the same price. You may know this if you've been to a hospital facility lately and you get your first statement, if you ask for what the price is, they won't tell you, and then your first statement is, this is not a bill. And yet there's pricing on it. And then later you get what you actually owe. That's because behind the scenes there's this reconciliation of buyer and seller, and you're not really the buyer, right? And that happens in the medicine side too. So there's a list price, which is really kind of meaningless, like the rate on the back of your hotel room door. It's sort of like a posted price. Only the problem is it's very regressive because there are a few people who pay that. They're the people without insurance. So to us, that's a dumb idea that the people with the least means pay the most, but that is actually the fact. And then, yeah. So as the manufacturer, we can change that to some degree if we can find those people. That's the $35 insulin comment you talked about, and we have other buy-down programs, et cetera. But that's a dumb idea. The biggest buyer, who's actually the federal government, has the best price, actually states by law have the best price. It's called Medicaid Best Price. And they get such a low price, sometimes it's well below our costs. So then you have to reconcile a price in between, the net price that balances all those things, and there's a lot of offsets and transfers and pieces that are cross-funding other things. But anyway, you can settle out at a net price for the US. That net price, despite all that, is still above what Europe pays, what Japan pays, other developed nations. I actually think that's not right. I think that those developed nations should pay a little bit more, and we should bring down the net price in the US a little bit more. And as a manufacturer, I actually don't care which country the revenue comes from, as long as we can recoup our investment and invest more in R&D. And that's another important point, which is we can make the prices go down a lot everywhere, but we would have no new medicines. And that's the quiet part no one's talking about. We could make the prices very low, and then we would just have no R&D, and then we would have no new medicines. And I think that's a terrible future, and we should not accept that. But some act like that's a realistic choice. I don't think that's a good choice. I guess it's realistic in a sense, but it would not produce good value for humanity. I think medicines do more than almost anything in the healthcare system to prolong life. Actually, that's what the evidence says. So we should try to find this rebalancing if we can. And then the first problem we should also address as well, which is this non-transparent net price finding system where the big guys get the best deal and the little guys get the worst deal. We're for a world where both those problems get fixed and we can keep investing in R&D and get a return so there's new medicines in the future. But as I said, there's not an elegant way to put all that together and solve it at once, although we're for that world. The administration wants to solve one part of that, which is this list price coming down and maybe a little bit of the net price thing, rebalancing Europe's payments for these medicines. That'll be difficult to do, but they're trying to change that. So I don't mind the direction. I think the method needs a little more sophistication.
How has your business, if at all, been impacted by reductions at the FDA, the NIH, outside funding for research and the like?
Yeah, so far, not really. And I think that's a little bit surprising. I think they've been careful, at least at the FDA, we have a user fee act. So actually, industry funds 85% of the drug part, the D of the FDA. And don't worry, we're not just writing checks under the table. There's like a method, and for each application, we pay an application fee, and then that funds the system. You may have something like this in your industry as well. It works pretty well, so that those that use the FDA more pay for more of it. And those scientists who do our review, there have been no changes in staffing. On the other parts of the FDA, I don't know, cosmetics, food, et cetera, probably there's been some impact. Within NIH, it's a very latent thing. It'd be hard to say, will that make a difference for us? NIH mostly funds extramural research, so grants to universities that pursue, novel scientific theories. Some subset of those turn into ideas that can become drugs. Almost none of them become drugs directly. That's what we do. We read about those targets. We create new matter that addresses that target safely. So in some future, GLP-1, that target was it was funded in part by NIH, in part by some European grants that found that target in the early 80s. And then it's till now, till we have drugs that people are using at scale. So it's very difficult to predict. But I would be for more NIH funding and not less, personally, just as a human. I think that's a good idea. Yeah.
Maybe the second most popular topic in the world, aside from GLP-1s, AI. Can you briefly tell us what impact that's having on your business today and maybe what impact you see it having in the future?
Sure. Although I think AI is beating GLP by a huge margin in most conversations and definitely in the stock market. Yeah, kind of incredible. I'm started my tech industry, so I'm a little bit of a tech nerd on the side. I'm enamored with what this thing can do. Also a little bit realistic as well. What I see now, I think you can think of this in three parts. The idea that machines can have intelligence and solve problems is a little overstated today. We know that as consumers, and as big companies, all the companies in the room probably have tried to use things like Microsoft Copilot or ChatGPT in your workforce, and it's probably been a little bit disappointing. I think if you use these general purpose consumer tools, you can find good value, but also some stuff that just doesn't work at all, and that there's work to do to make that really replace people. The one part of the white collar workforce that really it's doing a good job on is coding, and that's not so surprising because coders made AI, so they solved their own problem really well first. If lawyers had made AI, I think they'll get around to the lawyers soon. But it will happen. I think some of those those keyboarding kind of tasks have to be significantly enhanced and be more productive. That doesn't mean people won't have jobs. They'll just do other things. But so far, okay. There's a piece in the middle, what they call industrial AI. So this is taking basically free large language models and single purpose coding them or training them on an industrial task. And here, big companies have a massive advantage. I don't know if you see this at United, but we have, in some controlled settings, like in a manufacturing plant, really pristine data and no new variables, right? All the variables are our variables. So you can actually, it's a prediction machine. You can train it to predict the next thing really well. And it does it really well. And we have some use cases where we spent a couple $100,000 taking Llama or Anthropic's model or whatever that's free and open source and putting it to work, and it's like make us tens or hundreds of millions of dollars. That's amazing, actually. And so I think for big companies that have good data, this is what's ringing the register right now and is exciting. It's not displacing any jobs. Actually, it's just improving productivity in a plant or clinical trial or something. What's not yet here, but all the AI guys like to give speeches on, is inventing new drugs. So this is pretty nascent right now, although we're investing massively in this, and we have to do it ourselves because there's only maybe 10, 15 other entities on the planet that want to do this. But to take not language models, but large science models, basically, and create bespoke AIs that can do chemistry and physics and biology in a way that can make new medicines. I think we're on, maybe that's a 10-year scale to really have a huge difference. Although parts of that process are being worked up and working, it's a 100+ step process that we don't have a general purpose AI for now. But we have to do it because that's our core business and we can't let someone else do it. And we're investing extensively, and I am optimistic long-term that'll get solved. But we probably need better data. If you went to high school in the 80s like me, and you went back today, the chemistry class would be identical, the physics class would be identical, math would be identical. Biology, you wouldn't recognize. And so the biology is what we don't know enough of, and the computer doesn't know enough of. So it's very hard to train on an unknown data set. That's what needs to get addressed.
Well, we talked a lot about your investments around the country, and you're obviously investing billions in Indiana.
Yeah.
You're even investing money and developing facilities north of us in Wisconsin.
Kenosha, yeah.
And so my question to you is this. We have, a lot of movers and shakers in this room, and I would bet, give yourselves an applause.
Yeah, there's Chicago.
I would bet if we all put our minds to it, we could get the state to adopt the moniker Illinois Nice.
Yeah. So
if that happened, would you be willing to invest a few billion in the state of Illinois? And if you don't feel up to answer, you can hold on to it for a bit and think about it, and we can come back to it.
You're asking me, is Chicago my kind of town?
Yes, it's your kind. I get the sense that it may be, but again, you don't have to make that commitment tonight.
Yeah, absolutely. We're interested in a lot of places. I think we have tried, lately we've been trying to diversify our footprint out of the Midwest. Like, quick story, we're building a lot of these scaled sites. We'll have 11 new manufacturing sites in the US by the time we're done. And the constraint right now is actually people and laborers. So although we're not building in Illinois, I went to our mega site in Lebanon, Indiana. I have to say Lebanon, because if I say Lebanon, people kind of wonder what we're doing. Well, are you in Lebanon? No, Lebanon. But I met hundreds of workers from Illinois who are working on that site. Because, and this is a problem nationally, construction trades in particular, it's a 3 to 6 year apprenticeship. And we're building things fast. We can't, train these people fast enough. Our projects will be done. So we're pulling labor from all over the country into these projects. Yeah, we'll look at Illinois. Why not? Yeah.
Right. You heard it. You heard it.
Yeah.
It's on video. Well, Dave, thank you so much. This has been a wonderful evening. We're so appreciative, and we're very happy for you and Eli Lilly and all the success that you've enjoyed.
Well, thanks for having me. It's been a pleasure. Thanks.
This meeting is now adjourned.